Okay, this is the lecture for chapter 34, which is disorders affecting motor function. And I did take away some of the slides that were originally there. All right, so we start off with Parkinson's disease. So idiopathic, chronic, right, progressive, it is a degenerative disorder of the CNS, of the central nervous system. So if it's degenerative, that means that basically cells are dying, neurons are dying, and you have degeneration of nervous tissue. So there's motor manifestations, but there's also non-motor manifestations and also neuropsychiatric manifestations as well. For the most part, it affects individuals over age 50. There are, more rare cases where the age of onset can be earlier. It is the second most common neurodegenerative disorder. The first most common neurodegenerative disorder is actually Alzheimer's disease. And we didn't really talk about Alzheimer's in detail, but that is the most common neurodegenerative disorder. All right, so some of the symptoms, and we'll talk a little bit more about these symptoms, are tremors, bradykinesia, which is slowed movement, rigidity, and postural instability. Okay, so there are also some conditions that can cause secondary Parkinson's, and we're not really, going to talk about them too much. We're basically just talking about Parkinson's disease specifically, but head trauma, toxins, metabolic disorders, infections, also strokes that happen in that particular area that's affected by Parkinson's, the basal ganglia. Also, some atypical antipsychotics can also lead to some Parkinson symptoms, and also some antiemetics as well. Okay, so again, most of the causes are idiopathic. So about 90% of them have no known cause. There are about 10% of cases that are believed to be genetic. In terms of risk factors, right, increased age, male gender, it is more prevalent in males. Exposure to pesticides, metals, other compounds can also end up being a risk factor, and also a family history of PD. So just like all of these diseases we've been talking about throughout the semester, there always is some sort of genetic component. Okay, so in terms of the pathogenic mechanisms, the big one is up here at the top. So it says proteolytic stress, right? So accumulation and aggregation of abnormal proteins within the neurons. And I'll show you a picture to show you what specific area of the brain we're talking about. But basically, these are abnormal proteins that end up being misfolded, and then what happens is they aggregate together and they form what's called these Lewy bodies that are particularly an accumulation of this particular protein alpha-synuclein. And like I said, it's the neurons that are going to be affected by this. Okay, and so once these proteins accumulate within the neuron starts to dysfunction and ultimately will go on to die, hence why it is a neurodegenerative disease. Also, there are some studies that have shown that oxidative stress, mitochondrial dysfunction, and also inflammation play a part in the pathogenesis of Parkinson's disease. So we talked about oxidative stress before. Basically the generation of reactive oxygen species. So there have been studies that have shown that in Parkinson's patients, or basically in postmortem tissue, that there's a depletion of this particular antioxidant. Oops, sorry, that's a typo. And an increase in iron, which actually can promote the formation of reactive oxygen species. And so that's why they basically have implicated oxidative stress in this disease process. Also mitochondrial dysfunction. So there have been studies that have shown decreased mitochondrial activity, and also inflammation as well. Okay. And so this is actually just showing you a Lewy body in Parkinson's. Again, looking at some post-mortem tissue from a Parkinson's patient. Okay, so like I said, I was going to show you a picture of what part of the brain is affected, right? So the main area that's affected is the substantia nigra, right? So you can see this here. This whole area here is the striatum. Substantia nigra is here. So this one particular area is the area where you see the neurons die, and particularly it is loss of dopamine producing neurons in this area. Okay, so again, just a little more on the substantia nigra. It's part of the basal ganglia in the midbrain. It's involved in motor planning and reward seeking, And that is where you have the neurons degenerating. Again, those are neurons that produce dopamine. And so you have loss of dopaminergic neurons, okay, in that particular brain area. Okay, in terms of some of the clinical manifestations, it kind of has a slow progressive onset. And then, you know, kind of once you start seeing symptoms, then it'll start progressing a little faster from there. In terms of the motor features, right, tremors. And so there's this characteristic sort of pill rolling in this, you know, the tremor of the hand. And so it kind of turns in or kind of turns out. Also tremor of lips, chin, jaw, tongue, but basically you have tremors. Also rigidity from increased muscle stiffness, like I said before, bradykinesia, and postural instability. So we mentioned a few of these guys before. There's just a little more detail here. So if you look at this picture showing you these classic motor symptoms here, one is showing you facial expressions, right? The lack of affect. Also showing you tremors here. This pill rolling of the hand and that tremor of the hand, and this sort of characteristic kind of shuffling in terms of the gait. Okay, in terms of non-motor features, because there are both motor and non-motor features, fatigue, sleep disturbances, right, olfactory dysfunction, pain, autonomic dysfunction, and also neuropsychiatric symptoms, right? So incognition, dementia, psychosis, hallucinations. You know, I showed you the substantia nigra, and I said it's involved in, you know, reward motor planning. So also, right, mood disorders, depression, anxiety makes sense. Okay, so again, we typically think of Parkinson's as being, you know, a disorder that affects movement, but there are also many non-motor features as well. Okay, so this is just showing you the stages of Parkinson's in terms of, you know, diagnosing it and what stage you're in. And so obviously going from 1 to 5, the sort of most mild to the most severe here. And so you guys can kind of take a look at this, the difference, and you should know really the difference between, say, stage 1 and stage 4. Okay, so in stage 1, mild signs and symptoms, right, on one side only, maybe tremor of one limb, some changes in posture. Okay, once you get to stage 2, then you start to see more bilateral symptoms. When you get to stage 4, severe symptoms, rigidity, right, bradykinesia, but you still can walk to a limited extent. Okay, at this point, you're not able to live alone, and maybe the tremor is a little bit less, but you obviously have other symptoms at this point. Okay, in terms of treatment, one of the big treatments is basically replenishment with dopaminergic drugs. So as I told you, Parkinson's is due to loss of dopamine neurons in the substantia nigra due to, you know, various processes like we talked about, including accumulation of these misfolded proteins in the neuron. And so basically, you know, you can give dopamine agonists. You can also give a drug called L-DOPA, which is essentially a precursor to dopamine, that will then essentially synthesize more dopamine. So the bottom line is you want to increase dopamine levels. I have a picture that shows you a little bit more about the treatment and what's happening there. Okay. So MAOIs, monoamine oxidase inhibitors, we talked about, you know, symptoms of anxiety and depression, and so that makes sense there. Again, there are surgeries that can be done. Deep brain stimulation is also something that's used to treat Parkinson's as well. Okay, so if we look here, again, we kind of see what's happening, and I kind of showed you this already. Again, right in the striatum here is what's particularly affected. I showed you specifically that substantia nigra, but basically that's where you're going to have cell loss. Okay, and so you have this progressive loss of these neurons in this nigrostriatal pathway, and so so from the nigra to the substantia nigra to the striatum, and you know, these symptoms that we talked about already. Okay, and so here, so you have degeneration, and also if you're taking any of these antipsychotics, which are mostly drugs that will block dopamine, okay, it can basically exacerbate those symptoms that you see due to loss of dopamine, right? So if you already have too low levels of dopamine and you're taking a drug that decreases those levels even more, it's going to contribute more to these symptoms that you see of Parkinson's. All right, so for drug agents, like I talked to you about, dopaminergic agents, so we're increasing dopamine, right? So L-Dopa, like I mentioned, levodopa. Also dopamine receptor agonists, which will mimic the effects of dopamine, and cholinergic blocking drugs to help with the motor, the sort of unwanted motor symptoms that you see here. Okay? And so this is kind of just showing you here, again, like I told you, the levodopa is a precursor to dopamine, and so it'll get taken up by the neuron, and then inside the neuron there are enzymes there that will convert that L-Dopa into dopamine, and then it can be released by that neuron. Okay, and so again, this is because there are a significant loss of other dopamine producing cells, right? So this is helping to increase the amount of dopamine that's there. Okay. The next disease we're going to talk about is multiple sclerosis. Okay, so chronic inflammatory, basically a demyelinating and axonal degenerative disorder, right? So here, you're not necessarily having entire neurons degenerate or die. The loss really is of the myelin on the axon, and so it's particularly going to affect those axons. I guess if there's enough damage to the actual axon itself, then you can have neuronal loss from there. Okay, it is believed to be autoimmune. Okay, so that your body's immune system is what's attacking these myelin-producing cells, and thus you are losing myelin. Okay, and remember that myelin sheath. I'm going to show you a picture in a second, but that myelin sheath covers axons, right, and insulates them, and basically allows long distance, signals to be sent throughout the central nervous system. Okay, there are some risk factors: age, gender, ethnicity. I mean, this is all the same risk factors that we've seen before. Also, there is some genetics involved, but really, there's not really any specific cause, like it says here. Again, it's believed that it is an autoimmune reaction. Okay, so if you talk specifically about the pathogenesis, you have the development of these plaques. And basically those plaques are lesions that occur in the CNS, and common locations of those lesions are the optic nerve, brainstem, and cerebellum. And so usually, or in most cases, the first symptom that you see is blurred vision due to damage to the axons in the optic nerve. Okay, and these are, smaller axons, I guess you can think about it. And so a little bit of loss of myelin there is going to affect that type of neuron a lot more than a really heavily myelinated axon. Okay, so again, we said that demyelination is occurring as a result of an autoimmune reaction. And so it says here, it leads to conduction blocks and axonal degeneration. So again, if that neuron doesn't have enough myelin, it will not be able to transmit signals as effectively as it should. It doesn't always mean that it won't transmit them at all, right? But there's basically a lack of efficiency in that transmission. Now, it can lead to blocking of that impulse totally, but it doesn't always have to, okay? And again, if enough of that myelin is destroyed, the axon can start to degenerate from there. Okay, and like I said, once that axon degenerates enough, the whole neuron may end up dying, okay? Because it loses its target, essentially. All right, and then you also may see atrophy of gray matter because you have neurons actually dying due to that axonal degeneration, okay? And so, if you actually have neurons dying, then you're going to start to see a lot more symptoms and some cognitive decline from there. Okay, so this is showing you essentially what's happening here. Again, here's your axon, here's your myelin covering the axon, and again, normally if we're talking about an action potential traveling down the axon, right, it jumps from node to node. This myelin is very, very, super important in terms of allowing nerve transmission to happen over long distances. And so for whatever reason in MS, you have this destruction of the myelin, okay? And so now this axon will not be able to send its action potential down, right, down the axon to its axon terminal, and thus isn't going to be able to activate its target, right? or that transmission will be slowed down to a significant degree. Okay, and so this is just showing here again these immune cells that are infiltrating this area and actually leading to the damage of the myelin. Okay, so it says that initially, a lot of times when it's sort of initially diagnosed, it's sort of diagnosed just isolated, saying that there's basically a sort of episode of demyelination that has occurred. It doesn't, just that one time episode doesn't necessarily meet the requirements for diagnosis of MS, okay? There are 3 types of progression once you are diagnosed with MS: relapsing remitting multiple sclerosis, or RRMS, and most of the cases are this type of multiple sclerosis, and patients can remain pretty stable for 10 to 20 years. Secondary progressive multiple sclerosis, gradual worsening with or without occasional relapses, some minor remissions, and then also some plateaus. Primary progressive multiple sclerosis is more serious form. In about 10% of the cases, there are progressive deficits with some occasional plateaus and some temporary improvements, but for the most part, it is more progressive and more serious form of multiple sclerosis. In terms of clinical features, right, sensory symptoms in the extremities or face, like I said, visual loss, double vision, that's usually one of the first symptoms that will appear. Weakness, vertigo. There are many, many different effects, and this will definitely vary between patients and has to do with what, what axons are degenerated, right, and what area of the brain that's happening in, okay? One symptom here that basically I added a definition here is basically, this is impairment of adduction of the eye, right? So basically abnormal horizontal movement of the eye, okay? So it doesn't have to, it has to do with vision, but it's not really having to do with visual acuity. It's the actual movement of that eye itself. Okay, in terms of diagnosis, you're going to have to identify a CNS lesion, right? And you usually do that via MRI. Okay, there are also blood tests that will be done to rule out other disorders. Also doing EEG, right? And looking at evoked potentials, basically after you send a CNS response, right? So basically give a stimuli, see how quickly that's the central nervous system responds, right? Because again, that is assessing the transmission of the nerve impulses, essentially, okay? All right, so this is actually showing you an MRI where you can see some of these plaques, okay? So again, if you're gonna have a diagnosis of MS, you would basically obviously present with some of those symptoms that we mentioned, and also the clinician would be able to see these plaques in an MRI. Okay, so in terms of treatment, therapy that's going to modulate the immune system, we said for the most part, we believe this is an autoimmune disease. Therefore, you want to go at that you can go at that as the target. So you're not targeting the central nervous system, pathology essentially. It's the immune system, which is essentially what's causing it, right? That's what's destroying the myelin. You can take some drugs that are going to be effective against fatigue, really just to treat symptoms, okay? So there's really no, definitive treatment to basically, restore that damaged myelin, right? Also, physical therapy, nerve blocks, things like that can help with the sort of spasticity that you have associated with it. Okay, so that was multiple sclerosis. We switch to the next disease here. So amyotrophic lateral sclerosis, or ALS, or Lou Gehrig's disease. Most of us probably have heard of this. This is a progressive neurodegenerative disease. It causes weakness, disability, and death within about 3 to 5 years, and sometimes even sooner. And so you have neurodegeneration. So again, it is degenerative in either or both. I would say, I guess, both, but probably, it could potentially just start in one or the other. In upper motor neurons, in the corticospinal tract, right, in the central nervous system, also in the lower motor neurons, right, in the peripheral nervous system. So those are the motor neurons that directly innervate your skeletal muscles. But you also can have degeneration of those motor neurons that are much higher up in the brain, right? Coming down from the motor cortex. Okay. I do have a picture that I will eventually show you, just to kind of show you where the degeneration is occurring. There is no direct cause or mechanism, okay, at all, right? So for MS and Parkinson's, we definitely talked about a mechanism, right, in terms of what's causing the disease. We don't really know what's causing the degeneration, but we can pinpoint what's causing the symptoms that you see in the deficits. Here, we don't know why, okay? So it says motor axons die by Wallerian degeneration. Essentially, that is just when you have damage to the axon, sort of distal to the cell body, right? So far away from the cell body, you just get this kind of progressive degeneration from there, and then ultimately the neuron will end up dying, okay? So that's what this is saying here. And in this disease, that mostly the larger motor neurons are what is affected, okay? Again, axonal degeneration and cell death, right? It's degenerative. There are also these other factors that are involved in the degeneration as well. As we said, there really is no direct mechanism in terms of what's causing the degeneration, okay? So these are some things that we talked about before with Parkinson's disease, okay? So these are kind of just, there have been studies that have linked the symptoms that you see or have shown that you have this type of damage in the neurons in models of ALS. Okay, so I really just wanted to show you this because you can kind of see, I mean, at least a little bit of a picture here. It doesn't really show you the different spots on the cortex, but bottom line is if you're talking about the motor cortex, right, you're going to have neurons that are going to extend axons down to, you know, essentially, eventually to the spinal cord, right? And then their axons are going to extend out, and then there's going to be a couple of synapses along the way, right? But ultimately, their signals are going to be sent out to the muscle cells, right? And so you can have damage to motor neurons up here, but you can also have damage to motor neurons that are directly innervating the muscle. And those are the lower motor neurons. They're going to directly innervate the muscle. And the upper motor neurons are going to be up here, but they're what starts that whole, you know, pathway essentially, or that whole signal originates from that motor cortex, right? And then ultimately you have the muscle stimulated by that lower motor neuron. But if it's not initiated up here, it will never happen down here, okay? So again, it's the motor neurons that are affected, okay? It can be ones that are more higher up, the upper motor neurons, and also the lower motor neurons. So, and again, usually it's both, okay? Especially as the disease progresses. Okay. So in terms of clinical manifestations, again, it's sort of this slow, progressive, sort of painless weakness, right? So pain isn't really one of the major symptoms. It's weakness, and it's essentially atrophy of the muscles and eventually inability to even move those muscles at all, right? So upper motor neurons, signs and symptoms, particularly slowness of movement, stiffness, poor balance. If you talk about things specifically caused by the lower motor neurons, more weakness and muscle atrophy. But bottom line is these are going to, right, these upper motor neurons influence the lower motor neurons, right? They're all part of that same pathway, essentially. Also, you can see bulbar dysfunction. And so here, this will lead to, and has to do with basically outputs from a particular cranial nerves, a couple cranial nerves, and leads to dysphagia, hoarse voice, dehydration, and ultimately can, you know, not ultimately, but can also lead to choking. And also some dysfunction in the frontal cortex. Okay, in terms of diagnosis, right, clinical manifestations mostly. In terms of diagnostic tests, some nerve conduction tests, MRI, CT scan, muscle nerve biopsy. Again, mostly I think to rule out other things and pretty much those clinical symptoms that you see and that really serious progressive weakening and atrophy of the muscles is pretty unique to ALS. And there is a diagnostic algorithm that's been set up that basically combines these clinical findings with some electrophysiological findings, right? Again, these neurons aren't firing, right? They're degenerated, and so they're not even innervating these muscles or actually, firing action potentials to activate those muscles at all. And so you can assess that using electrophysiology, right? And recording from those, basically recording to see if those muscles are getting any sort of stimulation, right? All right, so again, stages, right? We talked about this with Parkinson's as well. And remember, this is progressive, it's severe, and usually patients die within about 3 to 5 years of diagnosis. Okay, so here you can kind of see there's a timing here in terms of these stages. And really, also these stages are describing sort of what parts of the body are involved. Okay, once you get to stage 4A, there's a need for a feeding tube, right? So there's about 77% of the way through that disease course. Once you get to stage 4B, you basically need non-invasive ventilation, okay? And then obviously, once you're getting to this point, you probably don't have much longer to live. Okay, so again, I said, survival rate about 3 to 5 years. The mean survival rate is about 3 years. In terms of treatment, there's really not much of a treat in the way of treatments. There's apparently one approved medication, this glutamate pathway antagonist, which has been shown to extend life by about 2 to 3 months. Okay, but nothing really that is effective. The only really treatments are to deal with some of the symptoms we just saw in that other table, right? Obviously, if you're going to need help breathing, you need to have ventilation, right? If you can't eat on your own, you need a feeding tube. Okay, so these are all just to really allow that patient to survive. There's really no treatment that's addressing the cause in any way, right? Or there's no treatment that's going to help get back these degenerating neurons. Obviously, there is no treatment for any disease that can replace these lost neurons. Okay, another one, Huntington's disease. So this is progressive, incurable, neurodegenerative, again, disease of the brain, okay? And it is actually a genetic disease. So it is autosomal dominant, okay? And it causes uncontrolled involuntary movements, dementia, and also behavioral changes. And the thing that's unique about, well, maybe not unique, because if you talk about Parkinson's, the age of onset is later as well. But the onset of symptoms is basically around 35, 44 years old. But the thing that is unique about this disease is that it is genetic, right? And so you may have already had children and you didn't even know you had the disease, right? Because the onset is around 40 years old or so. And so there's a chance then that you had passed this on to your children, and maybe basically a pretty sure chance that you did, since it is a dominantly inherited disorder, right? So in terms of duration, about 19 years, okay? The primary cause of death ends up being pneumonia or cardiovascular disease. In terms of the pathogenesis, right, I said it is a genetic disease. There's a mutation that's been pinpointed to this Huntington gene, hence the name Huntington's disease. And it's on the short arm of chromosome 4. And it basically encodes for this protein called Huntington. And what happens is when you have this mutation, right, you have this accumulation of this Huntington protein that will form these inclusions in the nucleus, right? Similar to what we talked about or what we saw with those Lewy bodies, different protein though. And again, this is the mutated form of that protein. It will alter transcription, alter transport, and will ultimately lead to neuronal cell death, okay? This is even some other processes that sort of occur once you have accumulation of that protein here, right? But again, ultimately all leading to cell death. Okay, in terms of the pathology, you have atrophy in the caudate nucleus and the putamen, okay? So again, atrophy meaning like, and I'll show you a picture, you can see that this area of the brain is basically completely lost, okay? So it says also by other selective neuronal loss and gliosis. So neuronal loss, gliosis means basically a increase in glial cells in that area where you had neurons lost, okay? You also see neuronal loss in the cerebral cortex. So you see atrophy in this one particular area, but you also see neuronal loss in other areas as well, right? So again, more atrophy maybe in areas of the midbrain, other areas of the midbrain, and also the cerebellum. So you can basically even also see shrinkage of the entire brain in general. So again, severe progressive loss of the neurons and atrophy of brain tissue. And so you can see why this really leads to pretty severe symptoms. Okay, so like I told you I was going to show you a picture here. You can actually see this caudate atrophy here, right? So I wanted to show you this so that you can see where the caudate is, basically here, right? So if you kind of look here, that's here, corpus callosum, and then here, see this is the ventricle, right? The ventricle here. You can see how much larger this ventricle is and how you're basically missing all of this brain tissue, right? It's gone. And so you can see this enlargement of the ventricle and decrease in brain tissue. So you can see how there's severe atrophy. And also if you look, you can see that there's much more white matter here, right? And a decrease in the gray matter, right? In the cortex. You see that compared this side compared to this side. Or in this, right? This patient compared to this patient. Okay, and so this is just kind of putting things into perspective, right? When we talked about Parkinson's, we talked about the substantia nigra. You know, we talked about the striatum in general, and not really this area of the midbrain is what's affected in Parkinson's. And so we're in a, we're in the midbrain, we're in the striatum here. Particularly, you see severe loss of the caudate, but again, also atrophy and loss of tissue surrounding that area and also in the cortex. Okay, so again, we can grade this disease as well. And so you go from grade 0 to grade 4, right? No detectable histologic neuropathology, no striatal atrophy. So this is saying in presence of clinical manifestations and positive family history, right? So there are some clinical manifestations that this patient is seeing. They did a genetic test. They confirmed basically that they have it, right? And maybe just from family history, but you also can do a genetic test to determine this for sure. As you move on from grade 1 to grade 4, you can see how this, basically that striatal atrophy, how it's getting worse and worse as you move on here, okay? So again, severe atrophy or loss of brain tissue. You can't afford to lose much brain tissue, right? And so once you start having neuronal loss and just basically complete loss that you can actually see, so vividly here, you're going to have severe deficits from that. Okay, in terms of some clinical manifestations, some Parkinsonian features. So there's a lot of different symptoms that you see with this. Carrera is abnormal involuntary movement and abnormal involuntary movement disorder. See tics, abnormal eye movements, rigid syndrome, and so sometimes you can see this myoclonus where you have these quick involuntary muscle jerks. Okay, so a lot of motor deficits, right? These are all affecting sort of involuntary movements. Also, you're going to see cognitive impairment, right? Short-term memory loss, impaired intellectual function, dementia, okay, and also behavioral changes as well, okay? And some of these behavioral changes may just be due to what's going on and the symptoms that are manifesting themselves, but also some of them are caused by the atrophy, the severe atrophy that's happening in the brain. In terms of diagnosis, again, right, you got a genetically proven family history, clinical presentation, and basically that genetic confirmation that you have the disease. MRI, CT scan can actually help measure how much brain atrophy is going on, okay? In terms of treatment, there really is no treatment, right? There are treatments just to deal with those symptoms, okay? There is no way of, again, reducing that neuronal loss that's occurring. Okay. The last part of this lecture is seizure disorders. Okay, so if you talk about seizure activity, what is that? So abnormal electrical discharges within the brain, basically this increase in activity, right? Abnormal increase in brain activity, basically a surplus of nerve impulses that are produced, right? A surplus of action potentials that are being generated, and basically a loss of inhibition, right? And so in terms of a seizure, you see involuntary movement and or behavior, sensory alterations. There's various things that can happen. If you talk about involuntary movements, it can be the entire body, but it can also be certain muscle groups only. You also see changes in level of consciousness, and I already said this, right? Sensory alterations as well. And so if we want to classify different types of seizures, we've all heard of febrile seizures. Maybe not, right? But these are seizures that will basically result from a rapid temperature rise above about like 102.2. And a lot of times you'll see these in infants and children. And most of the time, kids will outgrow these. They won't ever have them again. It isn't correlated with a future seizure disorder. It really is a sort of very specific type of seizure, right? So they're generalized seizures. They last only a few minutes. If you talk about partial seizures or focal seizures, these are contained within a limited area of the brain, right? And they can be simple, they can be more complex. So to talk about generalized seizures a little bit more, right? Again, you're having abnormal electrical discharges from both hemispheres of the brain, right? So a more general sort of presentation of this. And there are different types. So there's tonic-clonic, which is the type of seizure that most people think of when they think of a seizure, right? Loss of consciousness, violent muscle contractions really of the whole body. When you talk about an absence seizure, it involves brief, sudden lapses in attention, okay? So you don't have these violent muscle contractions or anything like that. Status epilepticus is basically a seizure that will last longer than 5 minutes, or the patient doesn't recover between repeated seizures. So therefore, it's essentially lasting longer. And this is life-threatening and dangerous. I think we come back to this in the next couple slides or so. In terms of generalized seizures, right, associated with loss of awareness or consciousness, and again, muscle stiffness and twitching. And so these were some of the types of generalized seizures that can occur. Okay, when you talk about phases, right? So tonic phase lasts usually about 15 to 60 seconds. That's where you have the muscular rigidity, loss of consciousness, the pupils are fixed and dilated, hypoxia, urinary and bowel incontinence, okay? Then that's followed by the clonic phase, which is about 60 to 90 seconds, okay? And so here you'll have alternating muscle contraction and relaxation, hyperventilation, eyes will roll back, and you'll see frothing at the mouth. And then the last part of it is called the postictal period. And so here you have a decreased level of consciousness, sleepy, right? Quiet and relaxed breathing. And basically you're sort of gradually regaining consciousness and sort of coming back or recovering from that seizure. Like I told you, that status epilepticus is life-threatening. Okay, so again, this is a seizure that lasts more than 5 minutes, or it's repeated seizures that a patient does not recover from in between, and you have enhanced and sustained electrical activity for over 30 minutes. Again, life-threatening. Okay, it's due to this increased neuronal excitation and, like I said, reduced inhibition, right? Basically, that's true for any seizure. Okay. All right, so in terms of diagnosis, right, there are various laboratory tests that will be done, complete blood count, basically to identify if there's infection or other abnormalities that might be contributing to the seizure. Blood chemistry, there's other things you might look for, but one of the big things is electrolyte imbalances, right? We talked about earlier in the semester the importance of electrolytes and that they are imbalanced, particularly if you're talking about neuron function, right? The two electrolytes that are particularly important there are sodium and potassium, right? And essentially, when you talk about the generation of the action potential, it is dependent on sodium and potassium. If those levels are in an imbalance, it can lead to this overexcitability of the neurons. Urine culture to check for drugs, right? Because drugs could initiate a seizure disorder. Basically, you're trying to get at or kind of see if there is a cause for the seizure, right? Or not, right? A direct cause. Maybe it could just be epilepsy, not just be epilepsy, but and would lead you to believe that it's epilepsy. EEG, right, to measure the electrical activity that's going on. And if you do have epilepsy, you will be, you will most likely be going for regular EEGs. Okay. Again, toxicology screening to make sure that there's not something else that's causing those seizures. In terms of treatment, there are anti-seizure medications, right? And so generally, these are medications that will increase levels of GABA, which is your inhibitory neurotransmitter, right? When we talk about a seizure, we're talking about overactivity in the brain, essentially, action potentials that are generated that necessarily shouldn't be. And so you want to decrease that activity by increasing levels of GABA, which is an inhibitory neurotransmitter. All right, and that concludes the lecture.